I'm Dr. Ray Fichier from Vet Triage. We are continuing through this issue of Veterinary Surgery from May 2022, and we are talking about doggy woggies. The determination of cutoff values on CT and MRI for the diagnosis of atlantoaxial instability in small breed dogs. This study comes out of University in Switzerland, the Research Center in Switzerland, vet school in United Kingdom, another vet school in Germany, Zürich, University of Zürich in Switzerland. The objective is to determine cutoff values for the diagnosis of atlantoaxial instability based on cross-sectional imaging in small breeds. Retrospective study, 123 client-owned dogs, 28 cadavers. Methods: the dogs were assigned to 3 groups: a control group, a potentially unstable group, and affected group based on clinical signs and imaging. The ventral compression index, the cranial translation ratio, the C1-C2 overlap, C1-C2 angle, atlantoaxial distance, the Bayesian dens interval, the dens to axis length ratio, power ratio, clivus canal angles were all measured on CT and T2 weighted MRI. They did this in flexed, meaning over 25 degrees, or extended less than 25 degrees head positions. So all those measurements, some are here, and I guess other studies have used similar measurements. Also, they mention here T2 weighted MRI. They did not base a study on other MRI sequences, so that's a problem. And of course, it's retrospective, so you're going to have the same issue we always have with lack of standardization between cases. Results found that cutoff values for the ventral compression index of 0.16 or more in extension and 0.2 or more in flexion were diagnostic for atlantoaxial instability, with a sensitivity of 100% and 100%, and specificity of 94.54% and 96.67% respectively. Those are very high numbers. Cutoff values for the other measurements were defined with a lower sensitivity ranging between 75 to 96% and lower specificity, 70 to 97%. Combining the measurements did not increase the sensitivity and specificity when you compare to the ventral compression index as a single measurement. So in conclusion, the ventral compression index, defined as the ratio between the ventral and dorsal atlantodental interval, had the highest sensitivity and specificity in both head positions. So that's pretty cool. All right, introduction. Atlantoaxial instability is most commonly observed in young small breed dogs and results in dorsal subluxation of the axis, leading to ventral compression of the cervical spine. It usually develops after minor trauma from congenital abnormalities of the dens axis and or supporting ligamentous structures. Clinical signs include cervical pain to tetraplegia and, in severe cases, respiratory distress and death. Diagnosis of the condition is based on clinical findings combined with radiographs or cross-sectional imaging like CT, MRI. Radiographic findings include dorsal displacement of the dens axis within the vertebral canal, increased distance between the atlas dorsal arch and the axis spinous process, and increased angulation between both vertebrae, and hypoplasia or aplasia of the dens axis. So those are all things you have to know for like surgery boards, for example. Quantitative radiographic criteria like a C1-C2 overlap is defined as the distance of overlap between the axis spinous process and the atlas dorsal arch smaller than 1.55 millimeters was found to be the most sensitive at 100% and specific at 94.5% radiographic measurement in the diagnosis of this condition in small breed dogs. MRI findings include elongated and thickened apical, alar, or transverse ligaments, and focal spinal cord signal changes. So in this study, they're going to look at the ventral compression index, the cranial translation ratio, the C1-C2 overlap, C1-C2 angle, atlantoaxial distance, Bayesian dens interval, dens to axis length ratio, power ratio, and clivus canal angle. Materials and methods. These cases were between 2006 to 2016. Dogs with an abnormal conformation of their atlantoaxial joint, consisting of a cranial translation of the dens axis in the absence of dorsal angulation, were classified in a third group, meaning the potentially unstable group. The head position was classified as extended when the angle of the head position was 25 degrees or less, or flexed with the angle of 25 degrees or more. And then this is a chart. I'll read this off as well, but for those who want to pause the video, let's see if I can help you out here. It has all the descriptions of what these measurements are for this study, but I'll read them as well. Angle of head position formed by the intersection of a line drawn between the tuberculum cellae and the Bayesian, and a second line between the cranio and caudal dorsal borders of the axis vertebral body. You're going to want to have probably an anatomy drawing to know what they're talking about here. The clivus canal angle is formed by a line extending from the top of the tuberculum cellae to the Bayesian, and the line parallel to the floor of the axis vertebral canal. C1, C2 overlap is defined as the cranial aspect of the axis spinous process to the caudal border of the atlas dorsal arch. A negative value indicates that the axis spinous process is no longer superimposed with the atlas arch. The Bayesian dens interval is from the Bayesian to the tip of the dens axis. The ventral compression index, and that's the main finding in this paper, is calculated by dividing the distance between the Bayesian and the midpoint of the atlas dorsal arch by the distance from the obsidian to the midpoint of the dorsal aspect of the atlas ventral arch. The ventral compression index, which is the main finding in this paper, is calculated by dividing the ventral atlantodental interval by the dorsal atlantodental interval. The atlantoaxial distance is from the caudal aspect of the atlas dorsal arch to the cranial aspect of the axis lamina. The power ratio is calculated by dividing the distance between the Bayesian and the midpoint of the atlas dorsal arch by the distance from the obsidian to the midpoint of the dorsal aspect of the atlas ventral arch. The C1, C2 angle is formed by the intersection of a line parallel to the atlas dorsal arch and the axis lamina. And then the dens to axis length is calculated by dividing the length of the dens by the one of the axis body. The length of the dens axis is defined as the distance between the tip and the ventral base of the dens. The length of the axis body is measured from the line drawn perpendicular to the axis body, passing through the base of the dens axis to the caudal aspect of the axis vertebral body. And then finally, the cranial translation ratio is calculated by dividing the distance of the cranial translation by the length of the dens axis. Okay, so here are some pictures that depict a lot of this stuff here. This is the ventral compression index here. This is the C1, C2 angle. This is the C1, C2 overlap. And this is the dens to axis length ratio. So, and for those who want to look close up of those, there you have it. Those are the measurements. And then the bottom picture. And the bottom one here, this is the main thing we're looking at here, which is the ventral compression index. It shows the method of measurement. And also note in these dogs, severe occipital dysplasia in both cases and the atlanto-occipital overlapping in case B. It's right here. And then for this picture here, measurement of the cranial translation ratio. Okay, results. Let's go. Breeds, most often Yorkshire Terrier, followed by Chihuahua, then a bunch of others. The mean weight, 2.68 kilograms. Mean age, 3.56 years. Dogs in the atlantoaxial instability group with head flexion were younger, with a mean of 1.7 years. Potentially unstable group due to the abnormal conformation of their atlantoaxial joint with a subjective cranial translation of the dens axis in the absence of dorsal angulation. And here's an MRI that we'll go over here. Those three there. You could pause that to look at them. This is in picture A. we have a physiologic atlantoaxial joint. Picture B, potentially unstable, and then C is atlantoaxial instability. With C, atlantoaxial instability, you see a loss of continuity of the cerebrospinal fluid dorsal to the dens, focal spinal cord compression, and medullary kinking, along with marked cervical syringomyelia. And then for those, so that's those, again, just those three pictures so you can know. And then here's a chart with all the measurements for those who care about the numbers. All right. The cranial translation ratio of 0.18 or more classified the patient as potentially unstable with a sensitivity of 90.48% and a specificity of 78.08%. Medullary kinking was known in every potentially unstable patient. The dorsal contact between the dens axis and the spinal cord, evaluated according to the loss of continuity of the cerebrospinal fluid dorsal to the dens, was present in 53% of potentially unstable patients and none of the controls. A step formation between the base of the dens axis and the caudal border of the atlas ventral arch and cervical syringomyelia were often seen in potentially unstable patients. The clivus canal angle was smaller in the atlantoaxial instability dogs in extension, a mean of 167.2 versus 174.1 in non-affected dogs, but was not significantly different in flexion between the groups. Discussion. The most reliable measurement, and this is what we care about here, because a lot of this stuff is like, it gets dry, and, clinically speaking, folks probably are not measuring these things. But the one measure being important is this one. So this is the ventral compression index. The most reliable method was that, which is the ratio which quantify the degree of dorsal displacement of the dens axis in relation to the atlas. In human medicine, the atlantodental interval anterior to the dens axis, corresponding to the ventral atlantodental interval in dogs, is used in the diagnosis of anterior atlantoaxial dislocations. Because the anatomy in humans, only the anterior atlantodental interval can be measured. The ventral atlantodental interval was shown to be significantly different between breeds and positively associated with the weight, whereas the ventral compression index is used in veterinary medicine as a relative measurement to overcome differences in patient size. So they found this study that the ventral compression index of 0.16 or more in extension and 0.2 or more in flexion could be diagnostic. So that you want to know for your boards. And that had a sensitivity of 100% for both measurements and a specificity of 94.54% and 96.67% respectively. Again, these are boards type of numbers there. The intra-observer reproducibility and the inter-observer agreement have been reported to be good for the anterior and posterior atlantodental interval on plain radiographs and on CT in human medicine. The ventral compression index was neither dependent on breed, sex, or weight, although it was found to be larger in females than in males in another study. It's also shown the ventral compression index did not depend on head position in controls, as long as the head is not placed in maximum flexion. A ventral compression index of 0.2 or greater in extension was associated with a sensitivity of 96.88% and a specificity of 98.63%. A higher ventral compression index measured on a neutral lateral radiograph projection of the atlantoaxial joint in dogs affected with atlantoaxial instability in comparison to controls, a cutoff of 0.348 or greater was 80% sensitive and 94.5% specific for atlantoaxial instability. A ventral compression index as a single measurement determining the ventral compression index may be sufficient to diagnose the condition. If the diagnosis remains unclear, they recommend repeating the exam in a slightly flexed head position, which is considered to be closer to dog's physiologic position in an awake state and could lead to dorsal angulation of the axis in cases with dynamic atlantoaxial instability. Another study reports that a mild degree of cervical flexion could favor the diagnosis in dogs. Hyperflexion of the head is contraindicated due to the risk of making the focal pressure of the dens axis on the spinal cord worse. Indeed, the ventral atlantodental interval as well as the ventral compression index was shown to be higher in maximum flexion compared to slight flexion and extension in controls. In the same study, a fixed cutoff value of over 10 degrees for the atlas to axis angle when the head was placed in slight flexion corresponds to over 190 degrees for the C1, C2 angle in this study. The reported sensitivity and specificity were 90% and 92% when this cutoff was evaluated for Yorkie Terriers, Chihuahuas, or mixes of these breeds. A defined cutoff value of over 187.4 degrees for the C1, C2 angle inflection with a sensitivity of 95.65% and a specificity of 96.7% is also a similar finding. A C1, C2 overlap of 2.7 millimeters or less in extension and 1.8 millimeters or less in flexion was diagnostic for atlantoaxial instability with a sensitivity of 84.38% and 95.65% and a specificity of 80.82% and 90% respectively. In another study, C1, C2 overlap was shown to be sufficiently different between breeds. A negative C1, C2 overlap was identified in 37.5% of atlantoaxial affected dogs. A negative measurement predominated in 80% of the examined atlantoaxial instability dogs when the head was placed in extension. In the same study, a C1, C2 overlap of 1.55 millimeters or less was shown to be most sensitive at 100% and specific at 94.5% on radiographs in the diagnosis of instability based on neutral lateral radiographs. Assigned to the potentially unstable group, those dogs had abnormal conformation of the atlantoaxial joint, which consisted of a subjective cranial translation of the dens axis in the absence of dorsal angulation or subluxation, medullary kinking, loss of continuity of the CSF dorsal to the dens due to its contact with the cervical spinal cord, and syringomyelia was often seen in the unstable group, potentially unstable. For this reason, they consider cranial translation of the dens axis as a possible early stage of instability, although its clinical significance has not yet been clearly determined. They found in this study that a cranial translation ratio of 0.18 or more classified the patient as potentially unstable with a sensitivity of 90.48% and a specificity of 78.08%. The need to treat these patients depends on severity of signs and on published recommendations. A ventral compression index of 0.23 or greater had a sensitivity of 93.7% and a specificity of 94.4% in the unstable group, potentially unstable. Dens axis hypoplasia or aplasia is well described with this disease. A report found a lower dens to axis ratio in atlantoaxial instability affected dogs at a mean of 0.36 compared to controls at 0.4. This finding has been confirmed by this study as well. The mean, now look at the abbreviations. The mean dens to axis length ratio in atlantoaxial affected dogs had a mean of 0.36 compared to controls at 0.4. And so in this study, 0.34 for the atlantoaxial instability group and 0.39 for the controls. The dens length was shorter in the atlantoaxial instability group than the controls, and the axis length was shorter in the atlantoaxial instability group than the controls. They found in this study that patients with a markedly low dens to axis length ratio are more susceptible to be affected by atlantoaxial instability. Also, a value of 0.24 or less was associated with 100% specificity and a sensitivity of only 21.88%, while a value of 0.35 or less had 100% specificity to differentiate between potentially unstable and atlantoaxial instability dogs, but the specificity drops when this cutoff value was used. For this reason, in this study, they recommend a cutoff value for the dens to axis length ratio of 0.24 or less as a diagnostic tool. The control dogs in this study were often positioned with the head in hyperextension, meaning a negative angle of the head position. As small breed dogs are commonly affected by occipital dysplasia, Such a position is discouraged to avoid atlantoaxial overlapping, which could cause compression of the cerebellum by the atlas dorsal arch. In conclusion, a ventral compression angle of 0.16 or greater in extension and 0.2 or greater in flexion is diagnostic, with a sensitivity and specificity of 100% and a specificity of 94.54% and a 96.67% respectively. In the case of cranial translation of the dens axis without dorsal angulation or subluxation, subjective criteria like medullary kinking or cervical translation ratio helps quantify the degree of cranial translation as a possible early stage of atlantoaxial instability. A cranial translation ratio of 0.18 or greater classifies the patient as potentially unstable with a sensitivity of 90.48% and a specificity of 78.08%. That's it. I mean, it's a good study. Obviously, I mentioned the problems with it earlier in the paper. For those who are specialists, they're going to find this way more useful than general practitioners probably. But I would stress the importance of, if you're going to do CT, pre and post CT, plus not just sagittal or axial views, but also coronal. And then for MRI, doing all the sequences, not just T2 weighted. That's just to be thorough because these dogs can have other issues too that can cause neurologic problems. So, all right, guys, thanks so much for watching the video. We'll see you again tomorrow. Bye-bye.